Welcome. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Today, we will learn about sleep disturbances and eosinophilic esophagitis from Dr. Reed Dimmitt. Dr. Dimmitt is a pediatric gastroenterologist at Dothan Pediatric Healthcare Network in Alabama. His clinical and research interests include pediatric gastrointestinal disease with a specific focus on abdominal pain, complex care, and eosinophilic diseases. He served as the division director of pediatric gastroenterology at University of Alabama and Children's of Alabama for 14 years before joining Dothan Pediatric Healthcare Network in January 2024. Welcome, Dr. Dimmitt.
Thank you. Thank you for the opportunity, Jennifer. Let me go ahead and share my screen. So I hope everybody can see this. We're going to talk about sleep disturbances, but I took a little liberty and kind of added pain because the two things are very intertwined. And I know there's a cross section of participants that are both family members and providers. And I wanted to kind of lay a little groundwork for probably more of the families that the providers know, at least have an understanding of some of the things we're going to talk about at the beginning, and then kind of go into the some of the research and kind of some future areas that might be helpful for our patients. But from an objectives, and so then we want to be able to understand the mechanisms of GI symptoms and pain, be able to understand somewhat the pathophysiology of eosinophilic esophagitis as it relates to pain, be able to understand the relationship between EOE, pain, quality of life, and sleep disturbance, and be aware of the factors in EOE patients with called disorder of gut-brain interaction, or DGBI, mediated symptoms and novel therapies. So it's a big thing. I want to make sure we leave enough discussion or time for discussion. A couple of caveats. I'm a pediatric gastroenterologist. I'm not a psychologist. I just partnered with a lot of them. And hopefully that some of it rubbed off and we can kind of talk about it. But I think there are some novel findings that might be helpful. And I appreciate the ability to do this when I'm on spring break. A few years ago, a pediatric surgeon friend of mine said his 7-year-old son came up to him and said, asked him what he wanted, or his father asked him what he wanted to do when he grew up. And he said, "I want to be a stranger." And he goes, "What's that?" "That's somebody that goes to the hospital for 3 days and doesn't come home." So I've always, every year, committed to making sure I have go to spring break with my daughter, who's now a senior and still asleep, although. All right. So let's first talk about models of pain. That's what we're going to do. So I do this a lot in my own practice in Dothan, but I wanted to kind of go over this with you. There's a couple of ways of looking at GI pain. There is what we call the structural model, and this probably accounts for maybe 10% of what we see as providers. And in essence, this is diseased tissue nerve endings traveling to the central nervous system and felt as pain. This is akin to having, say, a broken leg, where there is injured tissue and you have inflammation, or if you have an infection, or if you have something surgical. I think in America, and probably in a culture in general, and certainly in medicine, this is the big one that we all go to. This is the one that is scarier, I guess, in terms of what it potentially something could be, and it is certainly a cause and effect type of thing. What has happened over the last few years, though, is a new kind of model that's been coming out, and this will account for probably more than about 90% of our kind of symptoms, and it's called the biopsychosocial model. And in essence, there is no detectable structural disease that can be found with appropriate testing, whether that be with blood tests, whether it be with imaging, or whether it even be with endoscopy. And it really is an interplay between gut and brain. And this is the kind of what most people kind of talk about, the psychosocial model. You look at kind of the different domains that influence our symptoms and our behavior to those symptoms. And so certainly there are genetics, environmental things, maybe even certainly, unfortunately, sometimes abuse. There's obviously physiology involved. I think we don't quite understand that as of yet. That does involve enhanced or different sensation and different motility of the GI tract, resulting in symptoms, either be maybe too fast or too slow in terms of how it moves. And then life stressors and behavioral health, coping and support. And I don't know any pediatric patient right now that doesn't live in an ocean of stress in their world. And all these interplay and go into impacting our symptoms and behavior. And then this, when we look at the outcomes from that, and I think this is kind of what I think is different than looking at a structural outcome where you would look at a blood test or an X-ray or a histology that has shown improvement. These are different kinds of outcomes. This is use of maybe decreased use of medication, increased daily functioning, doctor's visits, and more importantly, probably in a global umbrella-like thing would be the health-related quality of life. And we'll talk about that a little bit here. So there is a group called the Rome Foundation, and they are an international group of pediatric and adult gastroenterologists that literally go to Rome. This is not for the providers, this is for the families. And they categorize a lot of these non-structural conditions. In the past, these were termed to be functional GI disorders, and they were, that term was somewhat pejorative in terms of they called it functional, which made it seem that they didn't really exist. And also people, both adult and pediatric patients with these disorders are not functioning. So the new term is called disorder of gut-brain disorders of gut-brain interaction, or DGBI. And this is the website. I just thought I'd kind of show it a little bit, but these are just a myriad of different diagnoses that are all based on symptom, but in the lack of any kind of structural abnormality. So there are chest pain, heartburn, and things. But a lot of what we end up having is a disease or disease called functional dyspepsia. And basically it's epigastric pain, or what they call postprandial fullness. In other words, you feel full after you eat, but in the absence of any detectable structural disease, including upper endoscopy. And so what we end up seeing is that when we look at the pathophysiology of eosinophilic esophagitis, it has some unique domains or characteristics that I want to kind of review real quick. So this is from NASPGHAN, the North American Society of Pediatric GI Doctors, and this is from their EOE slide set. And this is, again, the classic pictures where we would have that the esophageal mucosa, which is somewhat like skin, and we have allergens, usually food, but sometimes airborne allergens, that through a number of mechanisms, which we're not going to go in here, but there are a lot of genetics looking at cell signaling and mucosal permeability and then response and things like that, that recruit eosinophils that then populate in here. And then over time causes certain kinds of conditions. So initially they are inflammatory when you're young, and as you get older, it turns into more fibrosis or scarring kind of a thing. If you look at over age, this is an interesting kind of. This is again from also from the NASPGHAN, but from a paper published back in 2004. There are kind of some key symptoms associated with eosinophilic esophagitis. And it's all kind of predicated on how old you are when you think about this. So there is certainly kids that have feeding disorders. I used to help run the intensive feeding program at Children's of Alabama, and we saw a good number of our children who entered into our feeding problem, our feeding disorder program, that had either the presence of or a history of eosinophilic esophagitis. Certainly vomiting. Let's skip down to dysphagia. That's where it has difficult swallowing. This is when we've got inflammation of the esophagus. This is more when we have either sclerosis or fibrosis of this. But interestingly, 26%, a quarter of the patients that present with eosinophilic esophagitis present with either periumbilical or epigastric abdominal pain. And from a strict structural inflammatory process, this is somewhat of a disconnect, because you have inflammation here, you have inflammation here in the esophagus, you have fibrosis here or sclerosis here and fibrosis here. that's causing these. But this is where the inflammation is not where your pain is in these patients. And so this also is from the NASPGHAN website. But so pain with EOE presents in reported in different literature from 5 to 68%. It may not be a universal complaint, and it may be chest pain or abdominal pain, epigastric or generalized. Odynophagia is not typical. That means it hurts to swallow. And it plus or minus may be responsive to acid suppression therapy. So basically, we are presented with kind of two different types of of patients, and I kind of want to review this. So the workflow, again, this would go to our families as well as our providers, is that patients present to pediatric or adult, in this case, pediatric GI doctor, with specific symptoms, be it those things we talked about, more likely going to be pain that they'll, and we don't know what they have, right? So they undergo endoscopy, and when they kind of present with those symptoms related to the esophagus, these are patients that have structural symptoms, and they usually have some resolution with appropriate therapy. So not only do they show, they come in with a particular GI complaint, they then end up having appropriate therapy based on their eosinophilic esophagitis diagnosis, and then those symptoms resolve. But there is a second population that comes in, and they come in for some other mediated problem, a DGBI mediated problem, somewhat usually abdominal pain. And actually, it's where EOE wasn't really anticipated to be found, and it is an incidental finding. So this is often the common scenario, and this is for the rest of the talk, I really want to focus on this second group. But they are a patient that comes in, presented with their family, obviously with the family concerned how their child is functioning, what their symptoms are. They are given a diagnosis of EOE. They are then adherent to either dietary or now emerging new medical therapies. They show a repeat evaluation that shows remission, and then they're told your disease is under control based on this histology, looking underneath the microscope. But the ongoing original symptoms that brought them into the office in the first place have not changed. And ultimately, this is what interferes with sleep and the quality of life as it relates to health-related quality of life. So we'll kind of go into the bulk of this. So a number of years ago, I was fortunate to be part of a group at UAB at Children's that was a group of pediatric psychologists through UAB, and we linked this with our GI group to look at some relationship, if you will, between EOE and quality of life and other kinds of things. And I think this is this is what kind of is the springboard. This is our first paper, and this is Mary Lynch, who I believe now is in Indiana, but she was a very prolific researcher, had a lot of publications. She ended up doing her PhD at UAB and then did her postdoc at Cincinnati Children's, and has really been phenomenal in helping understand kind of how EOE impacts our children. And so first, the health-related quality of life focuses on quality of life and life satisfaction, and that HRQOL is a multi-dimensional concept. It has physical, psychological, and social functioning domains. Patients with EOE often experience negative changes in all three of the domains, and this paper was a systematic review of all the literature up to date that was designed to provide, again, a springboard into additional research to understanding why this is. And so this is a model that we came up with and published in that paper. And basically, we're looking at HRQL of both the family, but also as it relates to the parents and the family. So there's certainly a dynamic interplay there. And these are the things which interfered with high quality of life, and they were the kind of thing. And so if we had our symptoms and treatments, there was pain, and that was based on severity and interference in life. Internalizing, we're going to talk a little bit about that in terms of depression, anxiety, and we'll talk a little bit about stigma at the end. And also with sleep, that there was disturbances in sleep, both in the number of hours, but also the sleep quality. So because we saw that there was some sleep problems, and because we were somewhat linked with doing sleep work with with one of the other researchers that was in sleep medicine at UAB, we looked for does EOE interfere with sleep, and how is that linked with persistent epigastric pain? And so, again, what we hypothesized was that EOE with persistent epigastric pain would result in self-report greater current and worst pain severity. They would experience more disturbed sleep. So to do this, we recruited 50 eosinophilic esophagitis patients who were not newly diagnosed. They were ones that were had been diagnosed and had undergone appropriate treatment and had histologic evidence that their disease was no longer inflammatory. And then we also had 25 healthy controls. These were aged 4 to 12 years old. And so when we looked at our EOE patients, we wanted to have them equally distributed. So we had about 50-50 breakdown of those that reported persistent epigastric pain, so still had pain in the upper part of their abdomen or in periumbilical area, around their umbilical area. But we also had an equal number who denied any pain. So they're at that point, they were pain-free, essentially symptom-free. And so we used certain study measures, and this is where I'm way out of my league, but there were quality of life measures. And so there is a series of scales that allow you to measure quality of life. And so there was a pediatric quality of life eosinophilic esophagitis module, and we looked at scores there. We did just plain old pain severity, so whether it went from 0 to 10. And then there is a thing called SMFQ, which is the shortened mood and feeling questionnaire for children. And then we did sleep quality assessment with actigraphy. This is a very old modality, and this is like an older study, and I'm sure there definitely be more modern ways of measuring this. But instead of a standard sleep study where you have probes in your head and looking at oxygen movement and things like that, this was literally wearing almost like a Fitbit kind of thing on their wrist, and it would measure their disturbance. So it measured if they got up, it measured if they rolled over, how kind of good. So it was able to measure kind of a quality of sleep over a 2-week period is what we did. In fact, my daughter was one of the control group at that point. And so this is the 3 groups, and we'll kind of try to break it down here. But when we looked at kind of the demographics, they were all, the average was, about 8 years of age, because I always said it. As has been documented in a lot of research, and I think that it was predominantly a male-dominated, white male-dominated thing. There is some research out of that we've done that I've begged some people to publish, but when you kind of break this down, at least in Alabama, it's not as the racial difference tends to fall out, but that's a different study. And so there really wasn't any statistical difference here. But when we looked at the short mood feeling questionnaire in terms of what your feelings were, how you were feeling about kind of this global health, in terms of how your feelings were, the people who were healthy had a score of 1.24. Those that had EOE without pain had 2.46. But the lower the score is better here. So there was statistical difference across groups. but the patients with EOE and persistent pain had a much poor feeling of life. And then when you looked at screens for child-related anxiety and emotional disorders across the board, it too was statistically higher in the group with persistent pain. So when we looked also at pain severity ratings, and this is certainly self-propagating, I guess, in that when we looked at the three groups across pain, certainly the healthy group had no pain. The EOE without pain didn't have much pain, but the group with EOE with pain indeed did have pain other places. And worse pain severity, again, was much higher in this group. So when it looked at sleep disturbances, there was also waking and sleep efficiency. So sleep efficiency across the board was much lower in the EOE with persistent pain. And we looked at it at different parameters across the board. But most of them were related, at least statistically, to sleep disordered breathing, but also daytime sleepiness. And we'll talk a little bit about that as we kind of get in there. But while there wasn't really a statistical difference in sleep duration, we did see, going to the second point, that the disturbed sleep resulted in an average of 1 less hour of sleep per night. And when you did the math, that's the equivalent of a loss of an entire entire night of sleep per week. And as we also noted, that the patients with eosinophilic esophagitis that had persistent epigastric pain, they have worse pain and disturbed sleep. So we then surmised, was this unique? Was this at a quaternary deep south, greater Birmingham area phenomenon, or was this something that could be, extrapolated to other areas? And so when Mary was, this is an interesting story. When Mary went to start doing her postdoc at Cincinnati, and this is Cincinnati is the Mecca, I will grant you. But her initial saying, "Hey, we see these kids with pain in Alabama," and they said, "Well, we don't. We think the pain goes away." And she says, "Well, I'm not sure if that's true." As a postdoc, I was pretty proud of her for doing that. And so they basically just gave over all of their data on all these things. And she then was able to look at the same parameters with a group at Cincinnati. So it was a cross-sectional design of 91 dyads. So that's patients and families. And looked at two sites, at Cincinnati Children's and at Children's Alabama UAB. It did multiple analyses for health-related quality of life and risk factors, including sleep. And that really the only thing that led to having lower quality of life and poor sleep was persistent pain as that associated finding. So all of the downstream things that impacted these patients, from sleep to depression, anxiety, and everything, was all related to having persistent pain. So where do we go from here to kind of understand this a little bit better? So we are currently have submitted for publication the study, and I'm not going to go too much into it because it will still be under review. But it was really designed to looking at patients with DGBI pain. These weren't just EOE patients. These are patients with non-structural abdominal pain, and looking at what was the predictor for resilience and improvement in pain and quality of life. And again, kind of the bottom line is that there were kind of two factors that are the ones that came out. One, which kind of breaks your heart, is hope. And this is that somehow through this whole process of their pain and trying to relay why they had these pain and these symptoms, that there was hope that they would get better. And the second was validation. This was that the patient's symptoms were validated, that these were real, even though we didn't find anything that was traditionally abnormal. And so this validation had to be across all domains. So it had to be, the patient had to validate that this is the cause, parents, primary provider, GI doc, and most importantly, schools, because that's the thing. And we're also submitting some ongoing research looking specifically at the patients with kind of two populations with patients as it relates to self-stigma. And we'll talk a little bit about that. And so these are looking at patients with abdominal pain and EOE, and those who just have abdominal pain without EOE. So these are the next. And so there's a thing called self-stigma. And so what this is also driven by the confidence of cause of pain related to a various diagnosis. So as I mentioned, often patients with a DGBI mediated pain and poor quality of life and sleep are given either a diagnosis of normal histology in a lot of cases, or that they're given a diagnosis of eosinophilic esophagitis. Even though maybe their EOE didn't explain their pain, having a histologic diagnosis did help them with their self-stigma, that there wasn't something wrong with them, that they weren't making this up, that I had a proven disease. The thing which we're now looking at, is there a difference between self-stigma in terms of quality of life and sleep and things between EOE with pain and EOE without pain? Because what my hypothesis, a number of our study is that the patients who have persistent pain in the presence of eosinophilic esophagitis, who aren't getting better, have somewhat lost hope in that they are given a diagnosis. It should get better with medicines, and we've got these great new novel therapies, but they are not getting better. So there must be either something wrong with my physician who's not giving me the right medicines, or there's something wrong with me because I'm not responding to it, even though I'm being adherent to it. And that just kind of snowballs a circular pattern of anxiety and frustration and feeling bad about themselves. So lastly, over the last few minutes, and then we'll kind of open this up for some discussion and questions. But I think we need to kind of move beyond treatment of EOE from a biologic standpoint, but also then talking about EOE associated GI pain. So as we all know, certainly as family members here and as providers, there's been tremendous research into the mechanism of EOE, and this has resulted in the understanding of the biology and treatment of the disease. And it has changed the dynamics of how we even define it. It used to be PPREE, and then now it's all the same. So we've moved into, there's a subset to get better with PPI. There's those that get better with dietary restriction, and then also anti-inflammatory medications, whether it be making in your basement, taking topical steroids and making them as a slurry, to now where we have biologic injections, to the point where I'm sure we'll have a biologic oral medicines similar to what's happening in our inflammatory bowel disease patients. But across the board, in every family who has a child with this and every provider who takes care of these patients, the treatment for persistent pain remains difficult. And traditional medications that we all use for pain that are not related to inflammation are really pretty unproven in their efficacy. And that treating the underlying behavioral health problem with medications and cognitive behavioral therapy has shown to decrease symptoms and improve the HR quality of life. That was our kind of our standard thing. There are some new therapies that are coming out, and there's several on the market, but where, for example, using a nerve stimulator therapy that may provide additional adjunct intervention for our pain. So I think in conclusion, before we kind of open this up, is that pediatric patients with EOE are at risk for negative health-related quality of life and sleep disturbances. Jennifer had shared a great paper with me looking at, it was a group out of, I believe, out of San Diego, where they were looking at the quality of life and somatization and things of early diagnosis. So yes, this impacts quality of life early on in the diagnosis, even before it gets under control. But what we end up having is that we have a subset of patients who nobody thought they were going to have EOE. They have EOE. We treated their EOE, and they still have persistent, outcomes. And these are the ones that are likely to experience poor outcomes, including sleep disturbance. And that these patients may experience cell stigma regarding their response to EOE treatment, and that we definitely need to have additional research to understand the mechanisms of the DGBI pain, as well as development of effective therapies, especially in our patients with eosinophilic esophagitis. Getting back to that, the part about research, we know for the last 23, 24 years, I was at a quaternary care center in Birmingham. In the last 3 months, been in a rural pediatric subspecialty center in southeast Alabama, and the patients are exactly the same. So it is, whether it be at a referral center or more in a rural center, these are patients that are desperately in need of intervention to help with them. And I think that that's really where we're hoping with ongoing research to understand maybe the physiology of this kind of pain, and certainly with novel therapies to go forward to give them a better quality of life. So with that, I finished a little quick because I talk fast, but anyway, we can have maybe some discussion. There's a question: have you looked into how they sleep? The position is being vertical helps. My son has EOE and EOG, and some nights just holding him upright, seems to help. Was one of them. We did not look at that, and I think that's a good point. That would kind of be more, would it be clearance of acid, another thing that happens during the sleep.
Well, thank you for such a great presentation. Yes, so everyone who's joining us today, please open up that Q&A box and go ahead and start typing in your questions so that we can have a great discussion with Dr. Dimmitt here. Alrighty, so Dr. Dimmitt, can you share some more information about how people living with EOE and are having challenges with pain can be able to manage that and improve sleep? You shared a lot of great information about the fact that that's happening. Could you go a little deeper into the things that people can try to manage it?
There's not, and that's kind of my point is that so we I'm not lumping them into the same thing, but there is a huge subset or huge set. Most of the patients who get presented into a pediatric gastroenterologist will be coming in for Dimmitt, but a lot of them have abdominal pain. Some of those patients will have EOE, some of them won't. But then when we diagnose them with a non-structural cause of their pain, and they tell them to go find therapy, it's like, go find a pink unicorn, because those modalities of cognitive behavioral therapy addressing anxiety as kind of the big cause of things that interfere with their sleep and their quality of life. There's just not enough providers for that. Like I said, there's some novel, newer therapies such as nerve stimulators that may be out there, but I think we need to. My goal is kind of raise the awareness that these patients are out there, and that we really need to. These are kids that are missing months of school. Their families are going to have to go pick them up at school. These are kids who are having to repeat a year in school. They are ones that, and we're telling them that their EOE is under control. You're good. You should just be able to take a shower and go to school. And it's I don't think we're not taking care of them. We're not providing the best care. I'm not providing the best care.
Well, we appreciate that you're raising those questions so that more research can be done to help those individuals. So one of the things that you just touched on was a question that came in. Can you share more information about the nerve stimulator therapy? What is it and how does it work?
So I don't know. I just we're actually going to get one. There's several companies that make these. I'm not going to get into things like that. That wasn't my dog. Okay. So I used one back in the day, and it basically kind of you wear it behind your ear, and it's almost like an acupressure. You don't feel it because I wore one for a month, and it redirects some of these pathways. And so the feeling is that the nerves in the GI tract are misread by the brain as pain, or basically as pain, and then the body sends impulses back down to have some sort of response. And it's interesting when it comes to sleep and pain, is that a lot of our children with that DGBI mediated pain, some of their worst pain is at two times. One is in the morning. They're able, in the morning when they wake up and they're getting ready to go to school, and they have intense pain from anticipating the rest of the day. But the other group, there's other ones that also have it right as they're going to bed, and they kind of remove all the inhibitions within them, and they have and so that then gets back to impacting pain or sleep, because they're having pain, and if they're not going to be able to go to sleep, sometimes we're able, once they finally fall asleep, it may be disturbed, or maybe not, but that's really impacting them being able to go to sleep, with that. So hopefully,
really interesting.
yeah. And so I know where I'm at Dothan again. Just we're one of the companies that makes one of these nerve stimulators is coming and doing an in-service for us Monday the 1st when we come back. And but I remember when before you wore it for a month, you changed it every week. And there's great data. There's a lot of publications that it's been very helpful in helping with chronic pain.
Well, we look forward to hearing more once you learn more about it with that demo. Absolutely. So we've got a number of great questions coming in. So how are sleep disturbances treated when EOE is suspected cause of sleep disturbance?
Well, I think there's going to be two patients. I think there is the ones that still have ongoing inflammation, and I think especially when they were like the ones that were having to lay down, that maybe when it's not completely in remission. I think that anything that stimulates those nerve endings would interfere with that. But then again, I think the sleep disturbances, I don't think I'm kind of anti-medication. I don't like giving kids medicines to have them sleep or whatever. I'd like to find other ways of doing it. I will tell you that I really believe that the flow is, and I'm reading this, one is validate this is real, validate that the cause of this can be underlying anxiety and what's going on in these kids' lives. And that once we've been able to do that, then find the provider to be able to help address those types of things. This is not, I have an 18-year-old who has a DGBI diagnosis, and I'm a big believer. And I preached this sermon for 20 years. I've lived it the last 3 years, and it's impactful. And being able to find that connection and having those symptoms go away is what I'd like to see for our EOE kids that have that persistent pain.
Sure. So you talked about during your study that you had people wear different tools to be able to track their sleep. So some of the attendees want to know, should they be wearing devices to track their sleep and share information with their doctors?
I don't. I think we could say across the board, probably it's a thing. I don't even know if you can even buy actigraphy watches anymore. When I packed up my office in Birmingham to move to Dothan, I had a bunch of old ones that the batteries didn't work, so I just tossed them. But so I don't. I think when it comes to sleep, and I'm not a sleep specialist, but if we feel that there's sleep disturbances, actually working with sleep medicine, and I know that there's a number of places that have those. We have one in Dothan that it can do sleep studies to try to help that. And again, it's been more kind of looking at more breathing and oxygenation, but you also can look at quality of sleep, if they're concerned.
Sure. So you mentioned not being a big fan of medicine. Interestingly, we got a question about, do you know if there is a connection between EOE and low melatonin in kids with EOE, or adults for that matter?
I've not looked at that literature. I don't know. No.
See. Okay, so let's talk. I know you're not a psychologist and you have couched that, but we are getting a few questions about behavioral health symptoms. So do you think when someone has EOE that behavioral health symptoms are more related to EOE or to poor sleep quality?
Can you say that again? Ask that again.
Are behavioral health symptoms more related to an EOE diagnosis or poor sleep quality?
I think I think there is an interplay between the two. Um, I, I don't think, I think it's a vicious cycle is kind of what this is. Um, I think, I think a patient with, I think the worst case scenario here is if you have an inflammatory process like EOE, and then you also have a DGBI diagnosis, that you're taking a two-hit thing. So you have to treat your inflammatory process to prevent the sequela of EOE. So you don't end up having food impactions and need for esophageal dilatation when you're older. But then you have this other kind of pain, that's the other symptom of pain that is maybe interrelated, but it may not be. Which I think it kind of makes it maybe a little bit worse, because then I would think, looking at other, and we haven't looked at this, but other chronic diseases such as diabetes and everything that are related to ongoing anxiety, because you as a child who has a chronic disease, and so EOE would definitely be on top of this. You're telling a child he or she is going to have to be taking medication for his disease for the rest of his life, and well, we're all happy that there's injections for this. Telling that to a 6-year-old is like, I wait a minute, I got to take a shot, and so I don't know that that's really helping them with their global anxiety and related, to that. I say this I say this a lot of times in clinic, but I think what we all realized in March of 2020, and I do not ever want to go back to those dark days, but when my daughter was doing school on Zoom in the 8th grade, she was doing what I did in undergrad. And I don't know about other states around here. I will tell you that in Alabama, nobody does sports, cheer, dance, or anything for fun. They're on 17 travel teams and just all kinds of stress in them. And I think if we want to talk about the biggest stressor, and I know I'm all over the board, is this for our kids. There's papers done by the American Academy of Pediatrics that anxiety and depression is directly related to the number of minutes spent on social media. And so these kids are set up to be in this. And so we need to be committed to finding them, a better way of taking care of their symptoms.
Well, we very interestingly have a psychologist on, and she's sending us a nice comment that there is an interplay between physical health and mental health, and inflammatory diseases, according to her, can cause some anxiety. So one of the things you mentioned as a form of treatment was cognitive behavioral therapy. At what point, when you're helping a patient with EOE manage sleep and pain, do you refer them to cognitive behavioral therapy? And what is the goal of using that as a form of therapy?
So again, not the psychologist, and I didn't go in when my daughter did CBT, so I don't know. But it was a very short burst, as I understand it. I have several people that are pediatric psychologists I work with that do it, and it's pretty phenomenal. I mean, in a regular, like 3 or 4 visits, it's kind of like sports psychology is what I've kind of thought of. It teaches some biofeedback and some other things to kind of help them through a particular thing. And the research that I'm kind of aware of in some people is that the only thing COVID showed was that virtual behavioral health interventions are probably equivalent to live. So say, especially for where I live down in what we call the Wiregrass, that's the kind of the rural part of south of Georgia, Alabama, and Florida. If we can't find providers that there are using Zoom and other interventions, that a patient with one of these could get CBT, some period of school, go to the nurse office, connect on a computer, and be able to get that without having to get pulled out and literally drive 3 hours somewhere to for therapy.
Definitely has been incredible over the last several years to see how telemedicine and different things have been incorporated. So one person is commenting on something that you kind of referenced earlier. Their child has ongoing pain, but it seems to be the most significant at bedtime. And they're wondering if it's due to the calm and quiet that they focus on it. And the only thing that their GI has done is increased the PPI. Is there anything else you recommend they consider?
I really think it's the first. And I think the thing about cognitive behavioral therapy, there is a mind over matter or body kind of thing that occurs, with it. There is a way of being able to calm and self-soothe and all this. And I think when you, right, if they're ready to lose that inhibition or whatever, that I think that it comes storming, with them trying to go to sleep. That's a very common scenario that they said the pain is worse in the in the evening, and I think it's because of that. I'm not discounting, that there may be inflammatory processes going on, but I think there's certainly, it's probably not one or the other, but I do believe this is a lot of, it's more how these, at least from the research that the Rome Foundation has done, it's that particular individuals for, in their response, and it's not their fault, they're not making this up, is impacting how their symptoms are manifested. Getting back to that biopsychosocial model, that those domains, all three of those domains, whether it be physiology, genetics, and or stress, is playing a part in those symptoms.
So through the course of your discussion today, in addition to EOE, you've talked about DGBIs. And so one of the individuals listening to their son and it's currently they still have ongoing abdominal migraines that sometimes cause occasional vomiting, and they're curious, asking their doctor about DGBIs.
Well, so that's one of them. There are, if you want to go to the, I'm not sure if this is coming, if you want to go to the Rome 4, if you Google Rome 4 criteria and you go to that website, you're going to see so many diagnoses, in there. There's abdominal migraine, there's chronic nausea, vomiting syndrome, there's cyclic vomiting. All of these are real conditions. They're just related to a different kind of mechanism.
If someone is having trouble sleep and has EOE, do you recommend they consult their GI doctor, a psychologist, a sleep center, all of the above? Where do you think is the best place for them to get help?
I think the latter two would be where I would go with. I think certainly getting, going to sleep medicine to see if there's anything that they see, but then I think like I said, I don't know a child who's not anxious right now. So I think if that's part of it, I think addressing that, and I think a lot of your bigger sleep centers have embedded psychology in them.
You mentioned how you track people's cycles, and so one of the people watching is interested, does sleep schedule play a role or have an impact in pain and sleep challenges?
Oh, I mean, I don't know that. I don't know the data in there, but I think when I talk to my sleep medicine colleagues, having a schedule is really important. That it's the same way every night with them.
So I know you are a pediatric physician, but we've got a question here knowing, is there similar research being done for adults with EOE? Is that something you're aware of?
I'm not. I don't know that. And I do know that from a DGBI standpoint, that those diseases that are on that Rome 4 website are adult and pediatric. So those symptoms of irritable bowel syndrome and functional dyspepsia and chronic nausea, vomiting, and all these things are also adult diagnoses. So because that's a group of adult and pediatric GI doctors that they have it. So sometimes you can see these in very young people and very old people. I often have families come in, they say, I believe that IBS is inherited. And I'm like, I want to say, well, I believe your anxiety is, it's probably inherited because the room is just full, and it's real. I don't mean it like that, but it is a common thing across, even family lines.
What is the biggest takeaway you hope people have from our discussion and your presentation today?
I think the biggest thing is that it is important to continue to care for our patients with eosinophilic esophagitis from beyond we were really and rightfully so, fixated on understanding disease, getting rid of the inflammation, helping them with their symptoms related to eating and pain and swallowing and things like that. But I think we're doing our patients with EOE a disservice if we don't continue to treat and address ongoing problems such as sleep disturbances and as those that's related to pain. And our data would show that if we get rid of the pain, that our sleep disturbances will likely go away.
Well, thank you so much for your presentation and for your time answering all the questions today. We really, really appreciate it. We also want to make sure we take a moment to thank our education partners for their support of this webinar series. That includes Bristol Myers Squibb, GSK, Sanofi, and Regeneron. If you're interested in continuing to learn more about eosinophil-associated diseases, in addition to registering and attending our webinars, we encourage you to subscribe to our podcast, Real Talk Eosinophilic Diseases. In the latest episode, we talked with Dr. Amanda Moore about remodeling and eosinophilic esophagitis. You can find the episode at apfed.org/podcast, as well as on Apple Podcast, Spotify, Audible, and more. Another great opportunity to continue learning is to attend our annual patient education conference, EOS Connection 2024. Registration is now open at apfed.org/conference. We hope you can join us July 11th through 13th in the DC area. So definitely check it out. And we hope you can come join us in person or online. It is a hybrid conference. Finally, we encourage you to continue the conversation and the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. So thank you again for joining us today for APFED's EOS Support webinar series. If you have a question that didn't get answered today, please send us an email at mail@apfed.org. I hope everyone has a great afternoon.